So I'm going to talk about the global burden of RSV disease in infants, and so I'm going to restrict myself to children younger than 1 year of age. So before I start, some important disclosures. I've received some funding from the Gates Foundation and from Sanofi for RSV-related work, and then from Gates Foundation and Sanofi also for non-RSV-related work. Um, some honorarium from MedImmune for participating in an advisory board meeting, but none of this influences the current work just being presented. So today I'll talk a bit about the background of RSV and then talk about the process of RSV burden disease estimates for 2015, and then go on to present detailed estimates for children younger than 1 year. And because Lou is going to talk about the potential RSV vaccines, I'm going to look at the impact of some of these vaccines, particularly if they were given to pregnant women or to neonates at birth. So human RSV, what is it? It's different from the ovine or the bovine RSV. So it's a single-stranded RNA virus, and it has two subgroups, A and B. And on its envelope, it has a glycoprotein of F, G, and SH glycoproteins on the envelope. And it was isolated first in 1956 by Robert Channock. It's a ubiquitous virus in that children younger than 4 years, almost all of them get infected by this. And it's known to cause severe disease at the extremes of age spectrum. So in young children, particularly very young children, and also those who are elderly and those with comorbidities. So children with prematurity, bronchopulmonary dysplasia, congenital heart disease, and adults with chronic obstructive pulmonary disease. So briefly about the natural history of RSV infection in young children. RSV would present usually as an upper respiratory infection or a lower respiratory infection, acute lower respiratory infection. And these disease states, which are shown in orange or in red, are those that cause substantial burden on the healthcare system. So if it presents as a lower respiratory infection, which is what I'm going to be focusing on, it would either present as bronchiolitis or pneumonia. So about 85% of all RSV is bronchiolitis, but about 20% of these present as pneumonia as well. And it's very difficult to distinguish between bronchiolitis and pneumonia clinically. So we'll consider them together as acute lower respiratory infections. And then a proportion of these, about 10 to 20%, go on to become severe and could result in deaths. So we're going to talk about acute lower respiratory infections due to RSV, the severe disease, and also death. But the other important disease state that causes a substantial burden later on is the recurrent wheeze. So you have recurrent wheeze in infants and then in young children. And some of these children may go on to develop asthma as well. And although I'm not going to be talking about the sequelae of RSV and recurrent wheeze, Louis has published a very interesting paper a few years back in the New England Journal of Medicine looking at recurrent wheeze in young infants. And he's shown that if you intervene using palivizumab, then you can bring down the RSV-related wheeze by about 2/3. So going on to the global disease burden estimates in young children. So many of you may be familiar with previous disease burden estimates. That was the first global disease burden estimates for RSV published in 2010. And this was for the year 2005. And at that time, there were limited data that were available. But based on those limited data, we estimate that about 33 million episodes of RSV-associated ALRI occurred globally, and about 10% of these were severe enough to result in hospitalizations. We did not have sufficient data to come up with precise mortality estimates, but we gave broad boundaries for these estimates. So between 53,000 deaths in hospital to 199,000 deaths overall. And these were, as I said, based on limited data. So the in-hospital deaths based on 12 studies, and the upper boundary of 199,000 deaths, including those that occur outside hospital, they are based on data from a single site. So you take the data from there and extrapolate that to the entire developing world. But what we did show was that about 99% of all RSV-related mortality and about 93 to 95% of RSV-related morbidity was occurring in developing countries, so very substantial burden there. We did not have estimates for infants. We were only able to give estimates for under 5 children. So after 2009, there's been lots of activity in RSV. There's been a lot of activity on RSV vaccines. So Louis is going to be talking about that, but also RSV-related research. So I was funded by the Gates Foundation to set up the RSV Global Epidemiology Network, or RSV-Gen, of which Louis is also a member, and update the disease burden estimates for 2015. So we've had a couple of meetings, for the first one in 2013, another one in 2015, to pull together all the unpublished data that are from studies that are still ongoing or just sort of published, and to report these estimates by narrow age bands. So the data I'm going to present to you today is resulting from this particular exercise. So we were able to get data from 71 sites that report data for about 76 unpublished studies. So for this particular revised disease burden estimates, we did an updated systematic review. We identified more than 13,000 records, and then went through these papers and whittled down to about 225 articles that had data that were eligible for inclusion, and there were 76 unpublished studies as well that could contribute data. So in the end, we have data from 87 studies that report incidence or hospitalizations, 99 studies that report in-hospital case fatality ratios. So I'm going to be talking about data from these studies in my subsequent slides. But we have another independent data set that's about 199 studies that report hospitalizations in children without a clear catchment area, and the proportion of children who are RSV positive in these hospitalized pneumonia cases. But I'm not going to be talking about this because we don't have data for children younger than 1 year for from this particular data set. So we're going to focus on these two entities, and not all the studies which are included here have reported data by narrow age band. So we'll have to restrict ourselves in the coming slides to studies that are able to provide data for these narrow age bands. Before I proceed further, I think it's important to just familiarize with some of the case definitions that we use, and I'll be using these terms repeatedly through my talk. We have two kinds of studies. So one are community-based studies that are using active case ascertainment. So you have the health worker going house to house in a developing country, identifying children with fast breathing or cough or difficulty breathing, and then collecting samples from these children. So that's one spectrum, and you can probably catch all the children who have the disease state through active surveillance. But it's very expensive, only very few studies do that, and it's not generally done in industrialized settings. Then you have the hospitalized studies. So you have hospital-based studies that use passive case ascertainment. So you have children with who are sick, who are being brought to the hospital by their parents. So we've got this category of studies, and there are lots of studies in this. So any child who had cough or difficulty breathing and was tachypnic using the IMCI cutoffs and was RSV positive was considered as having RSV-associated ALRI. And if the child had lower chest wall indrawing and or danger signs, then we call this RSV-associated severe ALRI. If the child was hospitalized based on a physician's diagnosis of ALRI, so pneumonia or bronchiolitis, and was RSV positive on lab tests, then we consider this as hospitalized RSV-associated ALRI. Note that we use the term RSV-associated rather than saying RSV is a causal pathogen, because causality requires confirmation using various criteria, including the Bradford-Hill criteria. So for RSV season, which is important to identify for modeling the mortality estimates, any month of the year with more than 10 specimens that were submitted and more than 5% were RSV positive were considered to be within the RSV season. So this slide sums up the overall approach to the RSV disease burden estimates. Apologies for a very busy slide, But through my talk, I'm going to come and refer to this again and again. I'm going to refer to the bits that are relevant for that particular section of the estimates. So we'll start with the RSV-associated ALRI or severe ALRI episodes. So what we did was we conducted a systematic review of published and unpublished data, and then we did some imputation for the missing data because not all studies report for all the age groups. So we had to impute the missing data, and then we did a meta-analysis of the incidence for RSV-ALRI or severe ALRI by region. So we looked at it by World Bank income regions or by WHO regions, and then applied the population data for the regions and came up with the regional estimates for RSV-associated ALRI, and then totaled them up to come up with a global estimate. For the hospitalizations, a similar process was done. Again, a systematic review of published, unpublished data, imputation for missing data, and then regional meta-estimates to which population estimates were applied, and then you come up with the hospitalization estimates at a regional and then sum it up for the global level. So this slide shows the location of studies that report the incidence, hospitalization, and in-hospital mortality data. And the color shading for the different countries is as per the 6 WHO regions they lie in. The red circles indicate published studies, and the red triangles indicate unpublished data. And as you can see, for the developing countries, which are the South America, Africa, and Asia, the majority of the studies, about 60% of the studies, are unpublished. So substantial data coming from the RSV Global Epidemiology Network. Overall, we had data from about 157 studies. So this slide shows the estimates of the incidence of RSV-associated ALRI in infants. And so this includes the severe and the non-severe. So majority of the cases are non-severe here. And because these data are coming from the community-based studies, so you do not have data from the high-income or developed countries. So although stratified by World Bank income regions, what you see is that there is no data for high-income countries here, and so excluded that. The data in parentheses here that's adjacent to the income region is the proportion of under 5 children globally that reside in this particular income region. So what you see here is that for children younger than 1 year, we've again stratified this by age group, so younger than 6 months and 6 months to 1 year. The incidence is quite variable across the regions, and also there's very wide confidence interval because only very few data points that are used for reporting these estimates. And but it does seem that probably you have a slightly higher incidence in the children older than 6 months. Overall, about 13 million episodes of RSV-associated ALRI in children younger than 1 year, and about half of these are in children younger than 6 months. So now moving on to the hospitalization estimates. Again, now I've stratified again by income regions, and you have data for the high income region as well here. What you see is a very clear gradient. As you move up the income gradient, the hospitalization rates increase, and that's because of the healthcare seeking behavior and the access to health services improves as you move up the income gradient. But again, now what you would want to see is how does the hospitalization rate for children younger than 6 months compared to 6 to 11 months, and you see that there is a higher burden, higher hospitalization rates for children younger than 6 months in any given region. Overall, about 2 million episodes of RSV-related hospitalizations, and about half of these in children younger than 6 months. So how does this compare with data from other studies, cohort-based studies? There have been a few good cohort-based studies that have been conducted over the years, but one of the recent estimates that's from a cohort-based study was the one that was published by Caroline Hall in the New England Journal of Medicine in 2009. So this was for a 4-year period, this cohort from the US where she followed up. What you see is that there is substantial variability for any given age group, for a given across the given year. So the RSV related hospitalization rates vary year on year, which is what we saw as well. But also notably, the overall hospitalization rates for under 6-month-old children is lower than what we estimate for the high income regions. So we estimate about 26 hospitalizations per 1,000 children per year, and they estimate about 17 hospitalizations. So the RSV burden estimates overall appear to be in the same ballpark, but a bit higher. Okay, so this is about RSV-related morbidity, and as I said, we are reporting RSV-associated ALRI or RSV-related hospitalizations from ALRI. But how can we come across or interpret this in terms of causal attribution? So that's quite complex, but one of the Bradford-Hill criteria is to look at the strength of association. So, and you could do this by looking at doing case control studies and looking at the odds of having RSV isolated in children with acute lower respiratory infections compared to those who do not have acute lower respiratory infections. So they could be healthy asymptomatic controls, or they could be having upper respiratory infections. So we did a meta-analysis of all such case control studies that identify different viruses and report the odds of being hospitalized because of the virus. And what we find is the odds ratio is pretty high for RSV. It's about 10, and the attributable fraction in those exposed is about 90%. So what this means is about 90% of all these RSV associated ALRI cases could be causally attributed to RSV, but you need to confirm it using other criteria as well. So this slide now talks about the mortality estimates. So again, we identified studies that report in-hospital case fatality ratios and did a meta-analysis of these, and then apply the regional in-hospital case fatality ratio meta-estimates to the hospitalizations at a regional level, and then sum it up to get the global numbers. So this slide shows the RSV-associated in-hospital case fatality ratios in children younger than 1 year, and what you see here is data from 43 studies. So 41 of these are in developing countries. But what you see is that for any given age group and for any given income region, the in-hospital case fatality ratios are highest in the lower and lower middle income regions. So substantial mortality burden in these countries. The problem there being that many of these children who are hospitalized are only the severe ones, very severe ones who make it to the hospital. So a lot of children are dying outside the hospital in these regions. And we have no way of accounting for that except for modeling. So overall, about 2% in-hospital case fatality ratios, both in children younger than 6 months and older than 6 months up to 1 year. And if you apply this to the hospitalization rates, then we estimate about 43,000 in-hospital deaths in children younger than 1 year, and about 70% of these are in children younger than 6 months, a substantial mortality burden in hospitals. But this is just the tip of the iceberg. So we've previously shown that about 80% of all the pneumonia deaths in under 5 children occur outside the hospital, and we can estimate the overall mortality using modeling techniques. So, but what we do require for this are pneumonia mortality data in under 5 children and RSV transmission data. But we also know that from developing countries, the vital registration data are incomplete. So we can't use the vital registration data. We have to identify other sources of data for pneumonia mortality. And that could come from verbal autopsies, mortality surveys, or medical certification of deaths. We also, for modeling purposes, require at least 3 complete years of data, and we need to have a clear seasonality for RSV. And if there is shared seasonality with influenza, then we've used that to adjust for the influenza transmission. So what we did was, briefly, we identified sites with verbal autopsy confirmed ALRI mortality data in the community and RSV data for the same site for 3 consecutive years, and we estimate the excess mortality during RSV season. So we use a comparative or excess mortality model and attribute all the excess ALRI mortality during the RSV season to RSV. And then we compare the national level data on RSV mortality in the community to those in the hospital and come up with an inflation factor and apply those inflation factor to overall in-hospital mortality for developing countries and report the global RSV-ALRI deaths. So we got data from 3 sites, one in Bangladesh, one in Indonesia, and one in Argentina. So very different sites. And we used these data in our excess mortality model. The problem with an excess mortality model is that you're attributing all the excess mortality during the RSV season to RSV. So you end up overestimating RSV mortality. And although we adjusted for the shared seasonality with influenza, we've not adjusted for the other viruses that may be circulating around the same time. So you still end up probably overestimating RSV mortality. But equally importantly, we've excluded the role of secondary bacterial infection subsequent to RSV. And there have been papers in the recent past that have shown that the peak pneumonia mortality occurs immediately after the RSV season, and this has been shown from developing as well as countries as well as from the US. So when we've excluded these data, we've probably ended up underestimating RSV mortality as well. So it goes both ways. The inflation factor we talked about, that ranges from about 1.5 in Argentina to about 2.9 in Indonesia. So we took a mean of this and applied that. So overall, RSV mortality in under 5 children is about 118,000 deaths. So that's lower than what we reported previously, and that's probably in line with the falling pneumonia mortality overall in the world. So between 2005 and 2015, the pneumonia mortality has fallen overall by about 40–45%. So it's in line with that, and also that we've got more data points now. But more than 99% of these mortality are occurring in developing countries. We don't have data, national level ALRI mortality data for infants. So we've not been able to model directly for this age group. But if you took the proportional RSV ALRI mortality by age group, which were occurring in hospital, so that's about 73% of all in-hospital deaths occur in children younger than 1 year. And if you just looked at children younger than 6 months, then 46% of all under 5 RSV ALRI deaths are in children younger than 6 months. And if you applied these proportions to the overall deaths, then the overall RSV mortality in infants could be as high as 86,000. So what's the potential impact of an RSV vaccine if they were to be given in a neonate or to a pregnant woman in the 3rd trimester, so that the antibodies are passively transferred to the neonates? We don't have a vaccine yet, as Leaky said, and as Louis is going to show, but we may have a vaccine in the next 5 to 10 years. It's very promising. So we don't know what the efficacy of this vaccine is going to be, but let's assume that it's about 80% efficacious, and also assume that we'll have universal coverage, which is again going to be quite difficult. But if we assume universal coverage and assume that it'll protect until 6 months of age, then potentially this vaccine could prevent up to, in a very optimistic scenario, it could prevent up to 1 million hospitalizations. That's a big number. About 22,000 in-hospital deaths and 43,000 deaths overall. So this vaccine could have a major impact. And this is just looking at the individual contribution of RSV, but we do know that this vaccine will also reduce pneumococcal deaths. So it will have indirect impact as well. So in summary, about 13 million episodes of RSV-ALRI in infants, and half of these in children younger than 6 months. 2 million hospitalizations, again 50% of these in children younger than 6 months, and 43,000 in-hospital deaths from RSV, 63% of this in children younger than 6 months. 86% of all, 86,000 deaths, RSV-ALRI deaths in children younger than 1 year, and about 76% of this, about 43,000, are in children younger than 6 months, and more than 99% of all this mortality is occurring in developing countries. And vaccine that's aimed at pregnant women or for neonates is going to have a substantial impact on global pneumonia morbidity and mortality. So just to acknowledge the Gates Foundation for their funding, and my PhD students who's now graduated, Ting Shi for all the analysis, and members of the RSVGen group for their data, and also for participating in the analysis. Thank you.